Good morning or afternoon, again, depending on when you are watching this video. My name is Sarah, and we are going to do a brief overview of health behavior and theories and models, specifically as they pertain to health education being provided by community health workers. So I have three health belief models or theories I want to go over today. I think these are kind of the big three when working with clients that it's important that community health workers and other health educators be familiar with because they help us understand what motivates people's behaviors, particularly around health. And so the first one we're going to talk about today is the health belief model. This model was initially developed to understand vaccine hesitancy and uptake, and it really can be applied to any disease prevention strategy. You can use it, for, checking your blood sugar regularly for diabetes, or, checking your blood pressure as prescribed by your doctor if you have high blood pressure. So really it can be used for any kind of health condition, and we'll talk a little bit more about that as we go through this model. But there are some main constructs that everyone should be aware of. So when talking about health belief model, some of the things that we will talk about, you'll hear us repeatedly say, are perceived susceptibility, and that is someone's perception of how likely you are to get an illness or have the consequences of an illness. Perceived severity, and that's someone's perception of how severe it will be if they get the illness or have the consequences of having an illness. Perceived benefits, and those are the perceived benefits of stopping or starting a behavior, and basically what they will get out of it. Perceived barriers, those things that a client or person sees as a barrier to engaging or disengaging from a behavior. Likelihood of action, and that's basically the benefits minus the barriers. So if the benefits strongly outweigh the barriers, that they've got a higher likelihood of action. And then self-efficacy. That self-efficacy simply refers to someone's confidence or self-confidence in their ability. So this is a graphic representation of the health belief model. I think it's important to show the relationship between the constructs and how they can influence someone's perceived threat of disease and the likelihood of taking action. There are a couple of other constructs that are included on here that were not listed in the other slide. They are important to mention, but the reason I don't talk a lot about them is oftentimes we are not able to influence those things. So some of the modifying factors, such as their demographic variables, like someone's age, gender, ethnicity, those things we can't change. And then there's cues to actions, which you can create those however you like. Those are media campaigns, education campaigns. Those two I didn't include, but the rest are all in that previous slide and all play a part in someone's perceived threat and the likelihood of them taking an action. The next model we're going to talk about is the trans-theoretical model or theory of change. This model is designed to help understand and influence intentional behavior change, and really the focus is on the assessing a client's readiness to change. And as a health educator, it's an important role. It's a key role for you to be able to assess your client's readiness to change, because your interventions that you do with your client will depend on that stage of change. It does assume that behavior change occurs through a cyclical process, which will make sense when we go to the next slide. But there are 6 main stages to be aware of. So pre-contemplation, contemplation, preparation, action, maintenance, and reoccurrence or relapse. So pre-contemplation is someone is not ready to make a change. They're not thinking about it, or they thought about it, it's just they're not ready, they have no intention of doing it. Contemplation is they think about the change. They would like to change. Maybe there are a lot of barriers in play. Maybe they don't know how to change, but it's something they've thought about. They may even taken a few steps to try to make change and haven't been successful. Preparation is that someone has a plan to change. They want to change. They've taken steps. They are moving in the direction of making a behavior change. Action is that someone has made a behavior change. The person has quit smoking, for example. And the only difference really between action and maintenance is a time frame. Action is usually considered short term. Someone has made the change relatively recently, and then maintenance, there are different numbers out there, but 6 months is often the cutoff. If someone has made a behavior change and stuck with it for 6 months or more, they are considered in maintenance. And lastly, recurrence or relapse. Someone has relapsed or gone back into the behavior change, into a previous behavior. This model can be used, again, for lots of different behavior changes. I personally have a lot of experience with using it with smoking cessation, but it's often also used with clients with substance abuse disorders. And so I mentioned the cyclical process of behavior change. And so you can see here how they play into each other. And one thing with this slide, or something to consider, is that really these arrows can move backwards and forwards. Someone can be in pre-contemplation and jump to preparation, depending on lots of different things. And that could be the work that you do as a community health worker or a health educator, and providing them with some interventions or activities to do to kind of move them along the continuum. Something could have happened to them. So maybe someone who is a 20-year smoker had no intention of quitting, and then had a scare with some sort of cancer or precancerous nodule removed, and that can sometimes really make a huge impact in someone's decision or intention of making a change. And as I said, recurrence, someone can be in maintenance and be quit smoking for a year, and then something happens and they fall back and they are back in the pre-contemplation or contemplation stage, just depending on where they're at in terms of either trying to quit again or if they have no intention of quitting. But it's important to know that there is this cycle, and that as a health educator, or particularly community health educator, community health worker, health educator, you can help move your clients throughout this cycle by being very intentional with your activities, which we'll talk about next. And so to support your clients through throughout the stages of the change, the things that you may do with them. So for example, for pre-contemplation, they are not aware of a need to change. They don't want to make a change. You would have them often think about, hypothetically, if you were to quit smoking, or hypothetically, if you were to start checking your blood sugar twice a day, what would that look like? What would need to happen? And getting your clients to think along those lines. Oftentimes, particularly working with adults, they need to be able to come up with their own solutions and identify their own steps. As a health educator, you don't want to give them all the answers, because it's just not as successful as when a client says, well, I can do X, Y, or Z, or these are the things that would need to happen. And because then it becomes their idea, and it's not someone telling them what to do. And for each of these stages, again, for contemplation, oftentimes it's thinking activities. You may have them start with making lists of the pros and cons, or a list of barriers and solutions. For preparation, oftentimes planning is a big part. If someone is really wanting to quit smoking, more often than not, helping them create a smoking cessation plan it increases the likelihood of their success. Action, they have now met their goal, whatever it is, quitting smoking, losing 20 pounds, whatever it was. Usually activities that you work with clients on to help keep them in action, or some sorts of reward plans, how to keep them motivated and going with those health behaviors that they've engaged in, or that they quit. Maintenance, generally the support is minimal that you need to provide. You check in, see how things are going. Discuss if there have been any struggles, helping them identify ways to overcome those struggles, and helping them identify any triggers that they may have experienced. And then lastly, reoccurrence. Your activities with folks that have relapsed or in recurrence really depends on where they land back in that stage of change. If they're back in pre-contemplation, you start the process over again, thinking exercises, and etc. So really, it's important if someone has relapsed or fallen back into recurrence is to be able to identify where they're in the stage of change now. And the last model we're going to talk about today is the social ecological model. This model really reflects the idea that a person's health begins where they live, learn, work, and play, that there are relationships and communities and the systems in which people live and work all influence their health. And we also know that this idea that systems level policies have the greatest level impact. And so it makes sense more when we can actually show you what this model looks like. So the base level, the individual level, we know that this is one-on-one interaction, health education, and that you can have influence on a person's health, but being able to also affect the relationship level or the community level or even the system level, all of those interact with one another. Individual health can impact relationship health. So think about if you're working with a client and they have diabetes and you've worked with them for 3 or 4 months and they've really made a significant change in their lifestyle. They are more active, they eat more often than not, those health behaviors bleed over into the relationship level. Someone in their household, maybe their entire household, will have adopted similar healthy behaviors. And then if you think about impacting, multiple people within a family, their potential impact within the community, maybe they then take some of the things they learn back to their community organizations that they're involved in, or civic organizations. Maybe they take it back to their church, and church then becomes more aware of health behaviors, and the church adopts more healthy behaviors, maybe even adopting healthy eating policies. And then at the community level, if you have multiple community members or community groups, that's when you see community action being able to impact system level. And then it all also works the other way. And so with system level, if you create system level change, that tends to have the greatest impact on the community level, the relationship level, and the individual level. I'll give you an example. It makes more sense when I kind of explain it this way. So, for example, when they first required seatbelts to be installed in cars, there was a significant decrease in the rate of motor vehicle deaths. When they then made it, policy that people had to wear their seatbelts in their cars, that all now had seatbelts in them, once again there was a significant decline in the number of motor vehicle accidents. So you can have this huge impact if you can get that system level change. It is the hardest level to influence, but it has the greatest impact. All right, thank you for joining us. That was our overview of the 3 main health behavior theories that we often work with as health educators. And